I know I was meant to be having lots of cases in this, and that's originally how I started off presenting this. And I've again gone down a little bit of a rabbit hole writing this talk this week. So it's more researchy based, but I hope it inspires some conversation. So please interrupt me as I go, and I hope you enjoy some of this topic. So we'll talk about RV assessment in the critically ill, but as part of that, obviously, I want to try and I'll start off by talking a little bit about RV size and function assessment, particularly the pulmonary hemodynamics, and how we sort of look at the two of those things together. And as we go through that, we're going to talk a little bit about things like ventricular arterial coupling of the right side of the ventricle, this side, and touch on a few of the differences that are going to come about because of that, if I've got time. And I'd like to add in a little bit about Vexus at the end. So I'll start off with a case. We had a 65-year-old man. He's a Met call for a nasty VT on CCU. So this guy came into hospital the day before with some child's pubae, liver cirrhosis, and he was kind of lost to follow up for this. But then he comes in with this shortness of breath, has this weird-looking ECG. He's got ascites and peripheral edema, and he just gets put up on CCU with a furosemide infusion on some high-flow nasal prongs. And of note, 4 years prior, he'd had a normal echo. So they sort out this arrhythmia, but things get worse up on the ward. We bring him down to the ICU, and we noted that he's got this kind of pattern over the last few days that he'd been in hospital, getting his furosemide infusion and his arrhythmia sorted out. So we note that we've got a worsening acidosis with his bicarb going down. He's got escalating ureas and creatinines and elevating bilirubins. And you can sort of get that idea from looking at the urine here that bilirubin's going up, and as well how bad the urine output is. I mean, some of these things were screaming out to me that we needed to have a look at right ventricle function, because some of it felt a little bit odd for someone who was just being treated for an arrhythmia. And these were the kind of pictures that we found on examination of his heart. So he's got a markedly dilated right ventricle. That interventricular septum is pushed over towards the left side. He's got massively elevated right atrial pressure that you can see those big right atria with the interventricular septum pushed over towards the left, interatrial septum pushed over towards the left. He's got good going tricuspid regurgitation, which is at least moderate in severity given the PISA that you can see there. He's got thickening of that right ventricle free wall, suggesting this is not his first rodeo, that he's had pulmonary pressures that were elevated for quite some time. We've got a TAPSE that was relatively normal, but a fractional area change that was not. And on the basis of looking at the subjective assessment of that RV as well, and on my visual assessment, it looks like it's not working well at all. So that definitely put us into the idea that he had some form of significant RV dysfunction happening. Did our best to try and find a decent angle for this tricuspid regurgitation. So I'd like you to note that I'm off angle here, trying to get an axis down there, using the color to show me a nice direction for how to analyze that tricuspid regurg. And that's giving us a nice filled in profile there, again, indicating that we're dealing with probably severe tricuspid regurgitation with massively elevated pressures here, all the way up to close to 125 millimeters of mercury. Looking at the RVOT profile, you'll notice this W shape. I call it the flying W sign, or they call it mid-systolic notching, which definitely starts to indicate that there's, first we've got quite a rapid pulmonary acceleration time, as well as this mid-systolic notching, which puts us in this idea that we're dealing with pre-capillary pulmonary hypertension, as in there's something very wrong with the pulmonary vasculature or some kind of horrible lung disease. And then starting to use this more and more in my practice, that when I'm seeing right ventricle dysfunction, particularly if you've got acute kidney injury or LFT derangements, is then to start trying to have an assessment of congestion, having the idea that Maybe it's the RV dysfunction causing raised venous pressures. That's going to cause congestion in both your liver and your kidneys. And bearing in mind, you need like a pressure difference to create blood flow in your kidneys and liver. And so you can have a low pressure difference either because the forward flow is low, or as in this case, I think it is because the after flow is high, like there's horrible congestion, which means that you don't get a lot of flow across like a glomerular bed or the hepatic bed, and therefore you start to get poor flow within a kidney. And so we can start assessing some of that congestion with looking at the hepatic vein. First of all, you can see that this IVC is massive. We've got a lot of red flow in the hepatic vein and systolic flow reversal. It tells us probably that tricuspid regurgitation is severe and that right atrial pressure is seriously elevated. Looking at the portal vein, then, if we just go and have a look at the veins that's got more of a echogenic structure, and you've got it's mainly flow away from the probe, so blue flow away, but in this case you can see it's actually above the line, and this is again in the portal vein, that sinusoidal pattern suggestive of significantly elevated portal venous pressure. The last part of the vexus we'll look at is the renal flows, and again looking at this we can see this, particularly looking at the flow underneath the line here, and again this systolic blunting, very sinusoidal type pattern of this venous flow, the flow underneath the line, again, all pointing towards horrific venous congestion. Starting to use a lot of pulmonary artery catheters in this place. I think we got all of our information that we needed with echo, but the continuous monitoring that you'll get from your pulmonary artery catheter, which helps when then you're starting to institute therapies to try and help with this gentleman who's got some form of probably acute on chronic RV failure. And that's what's causing the symptoms. The arrhythmias are not a great sign and they're a complicating factor, but maybe the underlying thing that we really need to treat is as well as the arrhythmias, is this guy's severe right heart failure. And what was pretty impressive with this guy is that his pulmonary artery pressures are so high compared to his systemic pressures, almost like leading to this Eisenmenger's type syndrome that he was getting there, and these ridiculous V waves from the severe tricuspid regurg. So the cardiac monitoring devices, I don't think are useless in our practice in these cases. I think they really help as a, to be integrated with echo. You've got to use both of them. So they've both got strengths and weaknesses. And so we were using it in this case to try and help monitor response to therapies. And the therapies we tried were pretty extensive. We're using about 4 different catecholamines here. Started off with something like noradrenaline because there was a concern maybe there was some infection that was behind this with some of the history. Added an adrenaline in there to try and help with particularly RV function, trying to keep him a bit vasodilated. We added milrinone into that with sort of renally adjusted doses. And I think it was also just transitioned fairly quickly because he's also on metaraminol there. So, lots of different medications that have strengths and weaknesses based purely on pharmacological means that we take this, and we don't have a lot of evidence to support this. I said this guy was not for intubation. I think if we got to a stage he needed intubating, that was time out. And so, yeah, just managing this guy on high flow nasal prongs actually was what we tried to do, and avoiding hypoxia, trying to help with hypercarbia as best we could with increased flows. And I was also giving him some inhaled prostacyclin. So, in the end of the day, it probably doesn't surprise you too much. This guy didn't do very well, unfortunately, and he did die. But I think the idea behind it, though, was sound in terms of how to treat him, using echo to diagnose and monitor, using pulmonary artery catheters to help with that, and using that to try and guide therapy. And then working on trying with this gentleman, this acute on chronic RV failure sort of approach, which is obviously different from people who've got acute failure from other things. And we'll go through that if we've got time at the end. So I talk about this a lot, and I kind of present these kind of cases, I feel like, a lot. And I present them first and foremost, I think, because, I find that echo, so it's a really great way to show the utility of echo in caring for critically ill patients, because I don't really think there's anything else that we've got that's better in the acute setting to try and pick up RV failure. And if you miss it, it's a big deal. And I think the evidence I'm trying not to make sure I'm not biased because I love talking about the RV, but I don't think I am. I think there's some strong evidence out there showing that right ventricle function is massively important to consider both in the acute and the chronic setting. So here we've got some evidence from a single center study that's done for right ventricle dysfunction in mechanically ventilated septic patients. Again, showing the idea that if you've got RV failure as well as some RV systolic dysfunction, so the more they are together in terms of a dilated and abnormal right ventricle, that's associated with worse outcomes in mechanically ventilated septic patients. Some of the work done by one of our PhD students and respiratory specialist, Ben Gahadi, again, not showing too surprising, looking at all the literature that's been done, looking at longer term outcomes of patients where their right ventricle's been assessed when they were sort of acutely, severely unwell. So these are ICU studies, again, showing that there's a significant prognostic implication of someone who's having right ventricle dysfunction. We've looked at a lot of that in more specific categories of critically ill patients, and the particular ones that spring to my mind are ARDS patients and then patients who had COVID. And particularly with ARDS patients, this big meta-analysis done by Arota Sato, showing that you've got higher mortality with those with ARDS who have right ventricle dysfunction. And in some of the work that we did with the European group in particular, and what's known as the ECHO COVID study, showing that the worse your RV function was, the worse the mortality was. So again, it was significant, perhaps not as significant as we thought it was going to be honest, in this study that was particularly done during the phase 1 and 2 of COVID, but still showing that there was an importance of RV size and function assessment in these patients. So that it's it wasn't quite as prevalent as we thought it was, but it was associated with mortality is what I should say. And then this last one, which came out last year, this paper, which reminds me of why the hell we do research, right? Because, you look at these meta-analysis, I guess probably some of my own research has been in there, and, I sit there and I pat myself on the back that aren't I doing a great job doing research, but you actually then look at this amazing, I think this is a really great study that was done, an analysis of actually looking at trying to summarize all the knowledge that we've got on right ventricle dysfunction in ARDS. And this group, they found over 51 studies that have been done in critically ill patient looking at this, but there were like one or two of them, 6% of the studies were randomized control studies, and only 27% of the studies, they were only conducted with the goal of actually looking at what we do if we see RV dysfunction, how we treat it. So I think probably only having, is that 10 or 15 studies that are actually looking at how we treat RV dysfunction in ARDS. I think it's probably a little bit of a wake-up call for you, this about why we do research, and we're doing it to try and figure out how we make things better. I think we've got to a state now where we know how to examine it, and that's what I'm going to talk about in the next 15, 20 minutes. And what we now need to do is figure out what we can do to make that better, because it's highly prognostic in critically ill patients. Okay, so let's just really quickly flash through this because I know you guys understand it well. Great paper done by Antoine Villon-Baron, looking on right heart failures from a couple of years back now. And the main study talks about when you're assessing it, we have to look at size, and then we have to look at function. And function is going to include assessment of preload, contractility, and afterload. I'm probably going to just leave preload discussion for another time because I think that's a sort of different beast unto itself. And we're going to talk mainly about assessment of RV contractility and then afterload and how those match together. So RV size and function. So let's start with size. I think eyeballing it's probably one of the best ways of doing it. We're going to have a look at it in all views possible before we make an assessment. You could also probably have included in here, and if I could do this talk again, I'm probably going to add in a subcostal view as well as a subcostal short axis view. And then we can make our assessment. And we're looking to see if that right ventricle is about 60% the size of the left ventricle. We've got to be really careful not to be off axis in our apical four-chamber view, because if you're a rib space too high, you can foreshorten that picture, of course. So hence, one of the things I try to say to people as you're starting off doing echo is that if you see an RV dilation in your apical forechamber, one of the first things you've got to think is, have I foreshortened the image? And that brings me on to that second rule of Echo, or the second rule of Fight Club, which is that you don't call any abnormality based on one view alone. You've got to look at it across all the views you've got. So that's the eyeballing. The second one is you can make some measurements. I particularly make measurements. I try to make them as accurate as I can in that four-chamber view of that RV, and I measure the base, and anything over 42 is dilated. I measure the mid, anything over 36 is dilated, and I use that long axis, and anything over 82 millimeters is dilated. And then classically, I think what they say in the literature is if two of those are dilated, you call it dilated. It's either a dilated yes or no. Okay, so that's how you do the size. And then let's talk about quickly this assessment of RV function, or I think probably based off last week's talk, I should be probably talking about RV contraction rather than RV function, which is a more holistic approach. So let's talk about RV contraction, which is how my eyeballs assess it. So here in the parasternal long axis, I'm going to look at that bellows function of the right ventricle and how it's sliding across. It is a bit of a rubbish way of looking at it, but it's a start. And here I can see it's almost like you've got the RV free wall just rocking at the top and there's no bellows function moving down. So that looks abnormal. Apical four-chamber view, again, you're looking at that longitudinal motion, but also how that bellows function comes together and that RV free wall comes towards the septum. Short axis, seeing the interventricular septum pushed over, very little bellows function. And then the four-chamber view in your subcostal view, again, little bellows function. And you can imagine that fractional area changes down. We can look at our TAPSE. This patient there, when I thought this was abnormal RV function, you can see it's actually not as bad as we might think, but it's still low. Less than 16 and below is abnormal RV function. That's with our M mode. Got fractional area change in the four-chamber view where you do it at its maximum diameter versus its minimum diameter as a percentage. Anything greater than 32 is normal. So this one here at 25, it's impaired. We've got the TDI, which is tissue Doppler imaging. So that's how fast or the rate of movement of that lateral annulus, the tricuspid valve. And anything greater than 10 is normal, less than 10 is abnormal. And then the final one is RV free wall strain. So we're using speckle tracking there to look how those speckles move in a longitudinal motion. So from the annulus up towards the apex, and we get to see how those dots move, particularly in three different segments, the base, the mid, and the apical segments. And the magic number is about -21 or -25, depending on which guidelines you follow. And the more negative a number, the greater the contraction. So here we can see the curves coming together for the base, the mid, and the apex. And the more they come together, the better the contraction. This would be a sample of someone with normal systolic strain when you average them all together. So those are the ways I'm sure you guys all know and you're using all the time. But as we use them, we've got to know how to make them accurate measurements and know where the limitations are. I tried to look at some of this on I think it was around about 80 ventilated patients who had some form of PF ratio mismatch, so some form of VQ mismatch. So I think I said if you had a PF ratio, I think it was less than 200, you're mechanically ventilated, I'll put you in the study. And then I tried to have a look at things like RV free wall strain and TAPSE and compared them to subjective analysis. So that was me making the measurements, a single user making the measurements, trying to do it accurately. And then I sent pictures to, I think it was around about like 50 or so intensive care specialists who had qualifications in advanced echo. And then I'd ask them to make an assessment, mild or moderate, severe, normal, size and function. And if these are called plots or agreement plots. If it's black, it means that both the rater and the objective measure are exactly the same. If it's gray, it means you're one mode out. And if it's white, it means that you were two modes out. So for example, up at the top here in this agreement plot, this would be an example of someone that's got great agreement. And as you can look down here in this agreement plot, you can see quite a lot of gray, which basically means that there was okay agreement, but it was far from perfect. And the conclusions that we came to is saying that subjective assessment of RV size and function only has sort of moderate agreement with some of these more objective measurements, and particularly using RV free wall strain as probably one of the best markers of RV function compared to things like MRI. And then we came to this idea that, basically you just got to put it all together. I'm sure it probably doesn't surprise you to find that there's no echo parameter that's absolutely perfect. So you've got to use it all together and use your brain and understand the limitations of different measurements and then try and put it together. So subjective assessment, super useful to start off, but it's not the only thing that you should be doing. So how do you make accurate measurements if we're saying that we're going to make those? Well, first of all, if you're going to make measurements, you've got to make sure you're on the right axis. So if you imagine your short axis here, you've got to rotate that probe to try and make the RV look as big as possible when you're in your 4-chamber view. Because if you underestimate it by rotating one way or the other, you're going to make a bad measurement. So just try and make sure that you're absolutely on axis when you're making measurements. With your M mode, we are measuring longitudinal function with your M mode, and it shows it's pretty good versus MRI, but only if it's pretty good if you're actually measuring it properly. And so what we're talking about is that annulus moving towards the apex, because that's how that heart moves, right? The apex stays in the right position and the base moves towards it. So you've got to make sure you're imaging on plane, try and avoid what we call translational error when different parts of the heart slide into view, and make an accurate measurement of movement of the base towards the apex. Magic number being 16 and above, or 17 and above is normal, 16 and below is abnormal. Same thing's going to go for Doppler. That is angle dependent. So if you're doing tissue Doppler imaging, you got to make sure you're imaging it, looking at that tricuspid annulus moving towards the apex. If you're off axis, don't make the measurement. And then the final thought is looking at these regional wall motion abnormalities. So we see regional wall motion abnormalities if you've got chronic pulmonary hypertension and if you've got acute hypertension, acute raised pressures. So, for example, we've all heard of the McConnell sign. If you've got a PE, you get the relative hyperactivity of the apex. The other way can be around for pulmonary hypertension patients. If you've got chronic pulmonary hypertension, particularly if you get acute on chronic pulmonary hypertension, where you can start to see almost hyperactivity in the basal segments as compared to the mid and the apical. And that's what happened with this lady. So this lady's probably got some form of pulmonary hypertension, but you can see that we've got some apical hyperkinesis at the top. So this lady might have had some pulmonary hypertension there with a bit of a thickened wall, but the apical hyperkinesis is at play there because she's got this large PE. What can happen with that is you can get some form of tethering that happens pulling along those basal segments. So not surprising, this lady's got a normal TAPSE that sits in there, but a very, very abnormal subjective assessment, which kind of pushes us on to think about doing things like fractional area change. So often if your eyeball tells you that something's wrong, but TAPSE is normal, that's normally a cue for me to think about doing things like fractional area change to just support one way or another which way you're going. And if you've got a normal fractional area change, question your eyeball and make sure you're making accurate measurements. But in this case, I think it supported what we were thinking, again, suggesting that we've got at least some kind of moderate dysfunction going on with your RV. Okay, so those are just a few thoughts on tips and tricks with RV size and function assessments. And let's talk about pulmonary hemodynamics. So pulmonary hemodynamics, we're going to want to know about, systolic pulmonary pressures. We can also figure out diastolic or mean. And then particularly I use, things like pulmonary acceleration time. I like using, I know it's not everyone's cup of tea, but I do use the RVOT profile all the time. I think that's gold. So start with systolic pulmonary artery pressures. Again, as I'm sure you know, we try and make these accurate Doppler measurements for tricuspid regurgitation velocities. We find out what the Vmax is. From that, we can do 4V squared, add on right atrial pressure assessment, and we can get an estimate of systolic pulmonary artery pressures. If you did want to measure diastolic pressures, I don't do this a lot, I'll be honest, but you can use the PR end diastolic value, 4V squared of that, add on right atrial pressure, can estimate your diastolic pulmonary artery pressure. Guidelines talk a lot about mean arterial pressure for pulmonary hypertension. I kind of fudge it a little bit and use systolic pulmonary artery pressures as a fudge factor in there. But if you did want to be accurate, this is how you measure mean pulmonary artery pressure. You can just measure your, just trace out your VTI. In there, you'll have a mean gradient. Add that onto right atrial pressure, and you can use that for a mean pulmonary artery pressure estimation. Pulmonary acceleration time, it's been shown to probably be a best as a marker of raised pulmonary vascular resistance rather than actual pulmonary pressure as such. You can make an estimate of pulmonary pressure using some really weird esoteric massive equation with a fudge factor mixed in, so I don't use that all that often. I use a kind of cutoffs where we say greater than 120 is normal, less than 90 is abnormal. So if it's super steep, that's suggesting you've got increased pulmonary vascular resistance from something like PE, precapillary pulmonary hypertension, or something like that. And then the RVOT profile, particularly looking at an RVOT profile where we've got that mid-systolic notching. So that mid-systolic notching is indicative of pre-capillary pulmonary hypertension, and you don't see it so much for post-capillary pulmonary hypertension. And we'll come on to those differences in a second and why I think that those are important. But here you can see someone who's got something like a PE or some form of, chronic thromboembolic disease for pulmonary hypertension, or some form of nasty lung disease causing pre-capillary pulmonary hypertension. And you can see here a very short pulmonary acceleration time and the flying W sign, as opposed to someone who's got raised left atrial pressure or post-capillary pulmonary hypertension, where you won't see this as much. So show you some data of why I like these and why I think that they're important. And so this is just a review of sort of a three-year review of all patients that had an echo in our center who had septic shock. And from them is a retrospective review, so it's obviously a little bit dodgy, but you get the idea that we've got a few, over 100 echoes that we can have a look at, and we had a look at their pulmonary acceleration time and RVOT profile and their ejection time as well. And as we can have a look through their RV dysfunction from normal, mild, moderate, and severe, you'll notice that the pulmonary acceleration time gets lower and lower and lower as you get worse RV function. The RVOT VTI, as in how much blood gets pushed out of the RVOT, gets lower and lower and lower, the worse your right ventricle function gets. And the ejection time gets shorter and shorter and shorter, potentially because of increasing worsening pulmonary hemodynamics. Okay, so that's why I think it might be important to have a look at some of these factors. Again, we've got to know limitations when we're using Doppler. So right atrial pressure, one of the problems that we've got is we can only estimate from, we normally say it's like maybe about 3 or 8 or 15 millimeters of mercury. You can, estimate 20, but it doesn't really go above that. But I do like to use both Doppler as well as size and collapsibility of the IVC. So I classically use, if you've got a small IVC that's less than 2, completely collapsing, and you've got mainly systolic forward flow, that's someone who's got a RAP of about 3 to 5. If you're getting blunting of the systolic flow, you've got a big dilated IVC that's collapsing a little bit, that's someone who's sitting there about 12 to 15. If you've got no systolic flow, big dilated IVC that's not collapsing at all, 15 to 20 millimeters of mercury. So I try and use both together in making assessments of right atrial pressure. If you're going to make a measurement on tricuspid regurg, I put the color box on there first. I try and see the direction of that tricuspid regurg, and I'll put my Doppler angle down through that, just like I showed you in that first case. On the left side of the image, you'll see what happened if I'm imaging exactly on plane in a classic 4-chamber view, and I'll be about 30 degrees off if I was to measure this regurg jet direction. And so that's why it's important to slide round. It's what the little red marker there is, this cartoon on the right, and the white one there is the cartoon on the left. So the white's the standard 4-chamber view. The red is the off-axis imaging to get the absolute perfect Doppler angle. And that's what we should be looking for, so it doesn't underestimate any flow. When you get your Doppler profile, you're going to have what you're interested filling the screen. So you've got the line towards the top of the screen. You've got 3 or so cardiac cycles in the screen. You're optimizing your scale. You're trying to get rid of your the low flow dropout. Try and keep that as optimal as possible. And then you're going to turn down the gain, looking for the brightest portion. So when you look for the brightest portion, you're going to have often a lower value. You can see Vmax is like 3.6 here, as opposed to if you turn the scale up really high, you can, probably, exaggerate a little bit here, but, you've got 4.7 and stuff like that being made. And I love this little cartoon. It just reminds me of that cat on the stair with the sun behind it. The cat looks like it's massive. And if you touched its skin would be far outside it because you've got all the fuzz that's on there. So yeah, touch the skin of the cat. Don't just touch the top of the fur. So ignore the fuzz, or use my friend Faraz, who's got a massive beard. He always says, yeah, go for the chin, not the beard. All right. And again, so I talk about pulmonary hemodynamics with the RV, and that's why because we've got to remember that the RV and these pulmonary hemodynamics, they're all part of a bigger system. And I think sometimes at our peril, we put these in different segments, and I'm as guilty of this as always. I've spoken about LV last week, and now I'm talking about RV and pulmonary hemodynamics. Yeah, I talked systolic function, then diastolic function, then RV and pulmonary hemodynamics. If they're all different and totally separated, but they're not, of course, they're all together. One's affecting the other, because if you can get, poor systolic function, that can raise your left atrial pressure. That can then be felt by your lungs in pulmonary edema. That can increase up your pulmonary hemodynamics and cause worsening pulmonary hypertension. And that can affect your right ventricle function or right ventricle contractility, which can then lead to horrible congestion. I think we forget about this at our peril, that it's all part of one cardiovascular system and all linked. And I use that saying, you've got to see the whole heart. And that's what I mean by this, see the whole cardiovascular system, because one thing can affect the other. And that brings me on to talk a little bit about this part. And I'll show you why I think this is important in a moment. So this is where this idea of trying to understand, you can call them, I don't know what, phenotypes, I guess. That there are different patterns that you're going to see for different types of RV function or RV dysfunction. And it's really important that we don't just look at the RV in isolation and say the RV is bad, therefore I've got to, take fluid off, reduce the PEEP, maintain oxygen, reduce CO2. It's not that simplistic. And I think we've got to think about the RV as a whole. And the big example I'd have thought for this would be, for example, if we miss raised left atrial pressure, or this idea of post-capillary pulmonary hypertension, and you give someone a pulmonary vasodilator because you know that you're meant to give that to people with RV dysfunction, you may be doing harm to the patient because you vasodilate their respiratory system. And if you've got raised left atrial pressure, then you will just open the floodgates and flood their lungs with water. So it's really important that you consider things like left atrial pressure in your assessment of right ventricle failure. So you've got to have good assessment of the RV contractility, good assessment of the pulmonary hemodynamics, and good assessment of the left atrial pressure. So things like post-capillary pulmonary hypertension often have normal pulmonary vascular resistance. So that means that they don't have a notching. They have relatively normal pulmonary acceleration times, but they've got raised left atrial pressure. And that's not just E to E prime, but you're going to see that that's what they say in some of the literature. But I think you've got to use lots of things just to estimate what you think the left atrial pressure is. And on the other side of the curve, you've got pre-capillary pulmonary hypertension. So that's where the left atrial pressure is totally normal, but you've got rip-roaringly elevated pulmonary vascular resistance. And the treatment of these two things are very different, right? For the one on the left, when you've got pre-capillary pulmonary hypertension, that's where you've got normal wedge pressure. You've got to give them pulmonary vasodilators. You've got to try and reduce their pulmonary vascular resistance with dilators, milrinone, inhaled iloprost, prostacyclins, nitric oxide, things like that. Optimize oxygenation, CO2. That's all stuff that will help pre-capillary pulmonary hypertension. But if you've got post-capillary pulmonary hypertension, you've got normal pulmonary vascular resistance. What you need to do is offload their heart as best you can and provide them with inotropes. And that would be things like maybe levosimendan, dobutamine, adrenaline, maybe milrinone. And for me, this is what we should be looking at next. This is how we should be doing research next in the critically ill, using echo to tell us whether we've got pre-capillary pulmonary hypertension causing RV dysfunction or post-capillary pulmonary hypertension causing RV dysfunction, or a mixture of both. And depending on which category they're in, we should tailor our treatment accordingly. And maybe that's how we should be treating these patients. My guess is this is what we're doing. For those of us who are doing echo and thinking about this, we're probably doing this already, but we don't know whether it actually makes any difference at all. And I'd love to know the difference to that. I am by far and away not the first person to think of this. The best people to think about this is the cardiologists, and they came up with this wonderful idea, which was Greg Scalia, that legend up in Brisbane, and Playford and Jeff Strange in Sydney. They talked about the E-polar, and they thought up this brilliant ratio. It's not without its problems. I do think it's missing RV function, but I love their theory about it. That you just think about mitral E to E prime, and you just use that as a single value about whether you've got raised left atrial pressure, yes or no. I hope you'll take away from the last lecture that we did talking about, or the lecture before last about left atrial pressure. I don't think it's that simple in the critically ill, but I like the idea. But the idea is if you've got raised E to E primes and a normal pulmonary artery pressure estimated from your TRV max, if you've got a normal right atrial pressure, we should put into that. Right ventricle function, I should put it into that. Then you've got some form of raised left ventricle end diastolic pressure, and you've got to think about LV failure. If you've got someone who's got a raised pulmonary pressure with raised E to E prime, we call that post-capillary pulmonary hypertension. Raised left atrial pressure, raised pulmonary hemodynamics. On the other side, if you've got a normal left atrial pressure, but you've got raised pulmonary hemodynamics, that's someone with pre-capillary pulmonary hypertension. Okay, so they come up with E-polar. Great, nice, simple. I don't think it's quite that simple in the critically ill, unfortunately. So this is quite a busy slide, but I'll maybe have a chance to go to the actual reference underneath. But these guys go through in a little bit more detail, and I think this is probably the way we need to think about it a bit more in the critically ill, where we think about so pulmonary arterial hypertension, so pre-capillary, versus pulmonary venous hypertension, which is post-capillary. And they're suggesting, again, looking at things like RV size, which may or may not be dilated if you've got post-capillary. Think about the intraatrial septum and raised left atrial pressure maybe being pushed to the left, can be pushed to the right, but normally it's from the right to the left in the pre-capillary. RV notching super common with pre-capillary pulmonary hypertension. Often got a normal left atrial pressure in pre-capillary. It's elevated in post-capillary. And you can also look at your wedge pressure. So I like the idea, multimodality assessment. It doesn't have to take ages, but keep it quick and you can start trying to differentiate between one and the other. So why do I care about that? Well, this is some unpublished data that we've got from looking at a 5-year data set that we donated to the NEDA study, but this is basically just a retrospective review of every patient that had an echo in 5 years in our unit between 2017 and 2022. And then we looked at the E-polar and separated them out just on the E-polar. Again, not perfect in critically ill, but interesting to look at. And what was really interesting is that you can see in these Kaplan-Meier curves, both in sort of shorter term survival as well as longer term survival, that if you had a normal E-polar, so normal pulmonary pressures, normal Vmax, TR Vmax, normal E to E prime, your mortality was much better than if you had some form of left heart failure or if you had some form of post-capillary pulmonary hypertension. So this idea that if you've got left-sided heart failure, particularly if then is that affecting your pulmonary hemodynamics enough to affect maybe other things, that was really bad. And again, maybe potentially pointing to this idea that the left atrial pressure is a really important thing to look at in critically ill patients. And if we overload these guys, do we overload the lungs and things like that? And maybe what I haven't shown you is that this is even more important in certain subgroups, which is the highest one is, interestingly, respiratory. So if you've got a respiratory patient, this holds even more significance. We didn't publish this data because it's, I don't know, it's not perfect, and it's obviously a bigger retrospective, and we focused on other things like VA coupling, but it's worth looking at, and I think we should sort of look at this as a group sort of down the track. So what Emma's study made, oh yeah, please, yeah.
It's interesting that the pre-cap patients did reasonably well. Is that just because they had like reversible factors that led
that's
to
why we didn't publish it, because it didn't make sense.
Acidosis got better, and
we don't. I mean, it was the I've got to be honest. The cohort that we had was very unselected. You know, we're just talking about anyone that had an echo. We looked through the data. It took quite a lot to just clean up the data. So we used the ANZIC's core data as well as the NEDA, the echo data, and we only used those. So we didn't have all the data in it. So it wasn't perfect to be able to sort of dial down into this in a lot more detail. And that's why I think we're trying to do this with the prospective study now, where we can look at that data. And absolutely, there can be reasons behind it. So tell me, I'll be really interested to know, what kind of analysis would you want to look at hearing what I just said?
Well, I guess I'd just be interested to know what led to the pre-capillary patients falling into that group. So were they all of the patients with high peeps or significant hypoxia that then got better over the course of a few days? Or nice. Why did they almost reach the level of the E-PLAS normal? I guess it would just be physiological factors that led to reversal of their pulmonary hypertension.
Yeah, but they would be different if we stopped it at 6 months rather than going all the way out to sort of 5 years or whatever. You'd see that there is a difference between them, but not as significant as the post-capillary or LV failure, right? Yeah, nice. So it'd be looking at, I mean, I think if we were going to have a chance to do some subgroup analysis, it was looking at the effect of oxygen, ventilation support, pH, PCO2s, and things like that in there as well, right? Nice idea.
Yeah.
Thanks, Damien. Cheers.
Sam, quick question, and you might not know the answer, so I apologize if this is really particular. But the with the E-PLAR, tell me if I'm wrong. It's an average between the E medial and the septal and the lateral. Is that correct?
Yep.
And I wonder why, because like the E medial can be is kind of not suggested to be used in pulmonary hypertension. For left ventricular diastole. Why don't they?
Yeah, great comment.
Don't they use the lateral?
Yeah, that's a great comment.
I don't expect you to know the answer. It's just kind of weird.
I can't remember what they've looked down, and I think I'm saying it right. They use both in the E-PLAR literature, because I think you're only going to start to affect the medial if you've got significant RV dilation. And this is one of the problems I have with the E-PLAR, is that they don't take into account RV function, or an RV function which can make your TRV max low. If you've got shitty RV function, you can still have really high pulmonary pressures, but if you're not generating any force, then you're not going to pick it up, right? And that's why you need to look at your RVOT and your pulmonary acceleration time and your notching, right? And the RVOT VTI, I think I said, so it's not taken into account. So it's using these cutoffs that aren't perfect. But if you've got RV dilation, absolutely you're going to affect your medial E prime. But if you don't have RV dilation, you don't have horrible dysfunction, it's probably okay to average them out, as long as you don't have mitral anneal calcification, regional wall motion abnormalities, interventricular conduction delays, all the rest.
Yep.
Cool. It's just echo's not perfect, is it?
No, that's
isn't that a bugger? Yeah. No problem. Where did I put my? All right. Just to try and flick through it in time, we'll talk a little bit about VA coupling, but for the right side, and we got a little bit more detail on this in the critically ill. And I think this is a really interesting area. And again, I'll show you why based on some data that Emma's helped pull out. So, I showed you all that data talking about RV dysfunction, and not surprisingly, the worse your RV function is, the worse your outcomes. And again, I can show you loads of ARDS data where they talk about if you've got acute cor pulmonale, your mortality is doubled. It goes from ARDS patients' mortality that's like 30% in Antoine's papers from like 2010 or something. But then if you've got cor pulmonale, it's 67%. If you've got that severe RV dysfunction, you're buggered. And so I sort of come to this idea, and that's how I sort of started looking at RV free wall strain. We need to pick up RV dysfunction early, and we need to figure out ways to then treat that to stop someone getting towards severe dysfunction. And Emma's then taken it one step further and saying maybe it's not just looking at the RV contractility when that goes, maybe even that's too late. We need to find these groups that are at risk, and maybe that's where we've got to compare the RV contractility with the RV hemodynamics and look at true RV function, which is coupling. So the idea being that if you've got poor systolic function with an increased load, that's bad coupling. And the worse your coupling, the worse your outcomes are going to be. And we need to try and use that as the surrogate for true function, if you like. So Emma's done this. We've, the best that we had when we're using some of this data. And again, this is the sub-study data looking retrospectively again. So it's not perfect. So this is what was published. And this is why we went down this route, because it's a bit more impressive, to be honest. Is that she found these astonishing relationship between this RV-PA coupling, even with the data that was retrospective, so not perfect, but there was this astonishing relationship that if you had, the worse your coupling is, as in the lower that number is, and we used TAPSE over TR Vmax, you can do it over true systolic pulmonary artery pressure if you want to add on right atrial pressure, but the reviewers not unreasonably said, well, maybe that's a little bit dodgy in your cohort. You should have used CVP. So we just did it with the TRV max. And again, we found, though, that the worse your coupling, so for example, the worse your afterload is compared to your function, the worse your outcomes are going to be. And that kind of makes physiological sense and supports the idea that this is important in the pulmonary hypertension literature where it's absolutely shown, but I think it's also important in the critically ill literature. Last 2 minutes, let me just talk about the thing that I think is also really useful in looking in these patients, that if you've got some form of RV dysfunction, the reason why people die is potentially because of multi-organ failure. And if they're dying because of multi-organ failure, it's because of venous congestion in RV dysfunction. And that's where Vexus comes in. If you're not using it, I did a short little video that's on our YouTube channel with a guy called Shegan Olisanya, who's a legend back at Bart's Hospital in London. And he's the one that taught me how to do it. And we did this little tutorial on it together. It really is super easy. And if you're not using it, just have a crack. Watch that little video on how to do it. There's a few tips and tricks. You've got to set the settings nicely. It's all from these guys, Deschamps and André Denau, who are the guys that thought this up. And it's brilliant in its simplicity, right? You can't use it in all the ways that maybe it's been examined in. I've been told from talking to Shagan, it's RV dysfunction looking for congestion. That's what it's built for. You can look for it in terms of people who are fluid overloaded with congestion, but it's far from perfect. And you can't really use it to guide fluid administration. So that's my sort of understanding of the literature to date. And we'll just show you how to do it. I mean, so here's on the simulator. If you're looking for your hepatic vein, find your subcostal view, go to your IVC. In there, you're going to have your hepatic vein that comes off your IVC just before it enters into the right atrium. Put your pulse wave Doppler down through that, and that will show you a trace. And the trace is normally away from you with blood flow going into the IVC. And so you can look at how that systolic and diastolic flow pattern is, and normally systolic is greater than diastolic, as I showed you in that previous slide. Okay, next one is the portal vein. It's pretty easy as well. You can either use it in the same position and look to the left, or I go down in the right sort of mid-axillary line, going between two rib spaces, find the liver, and you're looking for blood vessels that have a slightly thicker edge. They've got more fat around them. And you're looking for blood flow that's going to be going away from the probe. So it's blue away and looking for blood flow in there. And that's where you're in your portal vein. Okay. And normally you're looking at just laminar flow, okay, that's coming towards you. Sorry, it's I said it wrong, blue away. It's red towards when you're coming this way. So blood that's coming towards you in the portal vein. So it's above the line and it should be just a constant flow. And then you can angle down to have a look at your renal veins. This is the tricky one. The other two are super simple. This one just takes a little fiddling with the settings. So once you've found your portal vein, just angle back and you're going to have a look through your kidney and try and find the little flow that are in the cortex. So you're turning down your scale, turn up your gain, have your low filters low so you can see low flows, and then increase your gate size, put it over that little, you'll often see a little sort of twinkling in there, and you'll get flow patterns that look like this. So in your hepatic vein, normal is here on the left, you get flow below the line, bigger than your diastolic flow, that is normal. When you're getting systolic flow going the wrong way, much bigger than your diastolic flow, that's congested. If you look at your portal vein flow, it's above the line, so it's flowed towards you. That's why you're looking for that red flow towards. And you've got this flow that's kind of laminar all the way at top, both in systole and diastole. As you get more congested, it gets increasingly sinusoidal, and you can even get systolic flow reversal and severe congestion. With your renal vein flow, you have arterial flow above it because that's the blood flow coming towards the probe, coming from the renal calyces up, and renal glomerular coming up, excuse me. And then it's venous flow below as it's going away from the probe back down towards the venous outflow. And so normal is this laminar flow. It gets more and more sinusoidal with systolic blunting as you get congestion. And this has been shown to be pretty useful. I don't think it's hard. And you get this idea that it's useful in looking for signs of congestion, particularly in right ventricle failure, as I showed you in that first patient. So that's where the importance of diuresis comes in to try and avoid this congestion and severe acute kidney injury and failure and worsening. You know, if you're getting oliguric, then you're getting worsening dilation of your RV, and that's just going to make the systolic function worse. So it's been shown to be useful in patients with heart failure, particularly right-sided heart failure, pulmonary hypertension, but just it can't be used just in non-selected critically ill patients or looking for, fluid overload in general. So I guess in conclusion, the assessment of RV size and function, try and be systematic. You've got to do it along with considering your pulmonary hemodynamics and indeed consider it as part of the cardiovascular system as a whole. So for me, if you're looking at that RV function and the pulmonary hemodynamics, include your left atrial pressure assessment and include your Vexus scans if you can, and then try to put that all together in the clinical story. Thank you very much. I hope that was useful. I didn't leave any times for cases. Apologies, but I hope you found that useful. I think it's a really important subject for all the reasons that I said, and I hope you carry on looking hard at your right ventricles.
Sam, I think there's a quick question in the chat.
Oh, I'm so sorry, I missed it. Thank you very much. When do we say RV dysfunction has translated to RV failure? Oh, great question. I should definitely have put that into the chat. So, okay, let's take the two extremes. So let's take the idea of someone who's got RV failure having been put on a ventilator straight away, and then that's RV dysfunction versus someone who's got RV failure. And that RV failure for me is both an echo diagnosis, which has to come with some form of clinical signs of congestion. So that's when you've got RV failure for me. So RV dysfunction can be someone where, for example, you've got maybe the TAPSE fractional area change or some form of contractility has gone down, or some of that early RV-PA coupling mismatch, that's where I'd start to be talking about RV dysfunction. That's when we're picking it up early. RV failure is when we're getting signs of congestion, and I mean biochemically. So that's where the diagnosis of cor pulmonale, for example, is a mixture of the echo signs of an RV dilation, RV dysfunction, contraction abnormality, and clinical signs of congestion. So be that unexplained acidosis, acute kidney injury, LFT dysfunction, ascites, pulmonary edema with peripheral edema with a relatively clear chest X-ray. So just to summarize that, RV dysfunction is probably just an echo picture of RV dysfunction. I describe that an RV at risk. RV failure is someone who has both echo and clinical biochemical signs of dysfunction. Do we say when the RV stroke volume drops? I always get interested, making me nervous thinking about a single parameter as being the be-all and end-all to describing this. What I love talking about with RV failure is that you've got to have some clinical integration into that. If we're saying that just based on one value, you've got to make sure you're measuring it right. I think you could probably say that if you're doing it over time, again, repeated assessment, but a single value of an RVOT that would be, so normal being 16. If you've got a single value of an RVOT VTI of 9, does that mean you're in RV failure? Again, I think that could be RV dysfunction. If something's not right, you're not pumping enough blood out of your RV, but you've got to be putting that into clinical context to call it RV failure.
Thank you.
What do you think? Did you buy it?
Yeah. Yeah, understood.
Nice. Well, thanks, guys. Are there any other questions? All right. Well, thanks very much for your time.